Good evening, dear colleagues. I am Dr. Moutaz Abdulmajeed, periodontist, the Syrian Board of Periodontology. I hope to spend a nice time with you in this evening. It's now our time in Dubai, 8 p.m. We are now going to discuss a multi-affected factors subject, which is the implant replacement, immediate implant replacement, and the different loading protocols. Actually, during the past 20 years before, we were focusing on different demands of the patients. The patient was asking just for an implant. He just need an implant. He wants to eat. He wants to develop the aesthetic appearance of his anterior region. But nowadays, some of these requirements has been changed. Now we are suffering from a patient which come to your office. Not you are the first dentist who will meet. He maybe met several dentists before coming to your clinic. He asks you a lot and a lot. We can call these patients as maybe it is accepted for you, Google educated patients. They have a lot of questions and we should consider their needs, their requirements. If we look to this diagram, the patient reported outcome measures. What our patients want from our treatment. In the field of implants, they are looking for the function, aesthetics, morbidity, cost, and of course, time. The patient needs these 5 requirements. The function depends on your implant system itself, the quality of the implant which you will insert it in his mouth. Most familiar companies are giving us high quality products which can reach to a nice functions in the needed functions in the mouth with longevity, high longevity, permanent longevity with our patients. And a lot of academic researchers, papers were noticed for the aesthetics, how to control the aesthetic requirements in the anterior zone. But our patient looking for morbidity, they don't like anesthesia. They hate our needles. They are maybe annoying from multi appointments. As you know, maybe for one crown, for single tooth implantation, maybe the patient come and back to the clinic maybe 7 times. So they are looking for less appointments. And of course, they hate our surgical protocols, which we need for bone expanding, which cause morbidity, trauma to the patient, or internal sinus lift, external sinus lift, GBR procedures. All of these procedures are not in the standard implantation. They are extra procedures. When we harvest connective tissue from the palate of the patient, that will not be good for the patient, who will refuse maybe the whole treatment plan if you give him that we are going to do another procedure and it is a little bit more harmful for you. So the patient are looking for less morbidity in the total treatment plan. Of course, the cost is very oriented factor to accept the treatment plan from your side to the patient. The patients want to reduce the costs. And of course, the time. Conventional implantation and conventional loading protocols duration is very long, maybe reach to 6 months or 9 months. If you do, let's say, external sinus lift. So the patient always ask us, and the trend nowadays, oh doctor, can we get immediate loading teeth? Can we shorten the whole duration of the treatment plan? So most patients nowadays are not patient. They are looking for fast treatment procedures, fast, and to reduce the time, the whole duration of the time of the treatment, from the first appointment of extraction of the tooth till the finishing outcome of the porcelain crown. Here we have some implant placement protocols, but first of all, we have to understand these terms. Immediate implant placement, which means that the same day of tooth extraction, you, the dentist, will insert the implant at the same extraction appointment. Get out the tooth and insert the implant directly. B, early implant placement. In many cases, which we'll see today, we need to go to another protocol of early implant placement to give the soft tissue opportunity to recover, complete healing. That is maybe about 4 to 8 weeks. Maybe we have to wait 1 month or 2 months to achieve this soft tissue healing, or maybe reach to partial healing of the hard bone. If we are going to wait for partial bone healing, maybe we need 16 or to 20 weeks. That means between 4 months to maybe 5 months of waiting. Finally, we have the late implant placement, when the patient comes to you and you discover that the extracted side was more than 6 months before. So for late implant placement, it is more than 6 months before the first drilling. Early implant placement, at least you are waiting for 4 weeks or 8 weeks. Immediate implant placement, the same day of the same appointment of extraction. For implant loading protocols, we finished implant placement protocols. If we are talking about implant loading protocols, we can define them as follows. Immediate loading. What that means? That means our dental implants will be connected to the prosthesis, whichever crown or bridge or other, and this prosthesis should be in occlusion. Here we have to notice that the prosthesis will be in occlusion with the opposing arch within 1 week subsequent to implant placement. That means you inserted the implant, you get the impression, whatever it is, a classical one, or you get it by intraoral scanner, send it to the lab, to the technician, and by the new techniques of 3D printing or milling, you can get a printed outcome that will be in your office at the same day, maybe after 2 hours, but not more than 1 week. So we can say immediate loading. That means you'll get connection between the prosthesis in occlusion with the implant in less than 1 week. The second protocol will be immediate restoration. Immediate restoration, similar to the past one, but here the process is out of occlusion. No complete touch with the opposing arch. The duration will be as the past one, 1 week. 1 week at most. If you can get it in 1 hour, it is preferable. If you can get it in 1 day, it is preferable, but not more than a week. The third is the early loading. The early loading, this terms means that our dental implants will be connected to the prosthesis between 1 week to 2 weeks, one week to 2 months after implant placement. So you will fix the prosthesis in the mouth till 2 months of the date of implant placement. And finally, the conventional loading, we know, we deal with it for a long time, period of time. We get the final restoration after at least 2 months of the date of implant insertion. Maybe we can make it after 3 months or 4 months. As the requirements of our patient are now increasing enormously, the science gives us a very nice concept to reach to this result. This new concept, all into physician's concept, all into concept. So we are talking about extraction and immediate implant insertion, getting the impression, sending the data to the lab technician, and in the second session or the second appointment, final restoration will be in the mouth of the patient. Look to this image. This is for upper molar, maxillary molar. You have to go to untraumatic extraction. And the process is very simple. First of all, you have to cut the crown till the level of the soft tissue. Then you can separate all the roots and clean the endocanals from any cotapecia. Then start with the initial part from your implant surgical kit. Start drilling in the center between the three roots, and go after that to the twist drill, the pilot drill, and you should put in your mind the 3D concept of drilling. That means you have to calculate the distances between the mesial and the distal sides, and the buccal and the lingual. And you have to go more buccally, more lingually than of being buccally. When you finish the needed diameter for your implant, you can insert the implant. Of course, we have to put in our minds several matters to be concerned. Before starting this surgery, I have to calculate everything from the clinical side of view and from the information which we get from the data of CBCT of the patient. I have to ask myself as a practitioner, as a surgeon, how long time I should wait to install the superstructure. Could my implant system have self-tapping in the extraction socket? How I have to determine the implant positioning, the implant correctly angulation in the socket? Maybe I can use a surgical guide for this noble aim. How do I take an impression at the same time? Can I use the intraoral scanner? How do I transfer the data and the impression I get it to the lab technician? How does the technician lab create the gingiva emergence profile, which will be the profile of the future crown? How to maintain the emergence profile over time? How to reach to nice soft tissue around the final crown? So we have to put in mind the thickness of the soft tissue. We have to put in mind, if it is possible, go to keratinized soft tissue and attach gingiva to the bone as possible as well. All these issues should be discussed in my mind before starting such a procedure. Okay. Look here, this is immediate insertion after extraction. At the same time of extraction, we have to insert the implant shoulder to be less the top of the crest, maybe to 1/2 millimeter. Try to, for the angulation and the position, be in the middle between the mesial root and the distal root as possible. And of course, you have to insert your drills to be in parallel to the besides to molar and premolar. After finishing implant insertion, for this case, you have 2 implants, one for the second premolar and the distal one is first molar. After finalization of implant insertion, we insert, of course, the scan body and get the impression, the digital impression. After that, we screw out the scan body and insert temporary abutment for both implants. And as you notice here, we start injection of flow composite over the implant and around the temporary abutments. And of course, we have to light cure this flowable composite. Don't put the whole amount of flow composite at the same time. Put just little bit quantities, cure, add more flowable composite, and cure time by time to get a nice emergency profile. This is the final result, the complete amount of flowable composite has been finished. And we screw out the transfers. Sorry, we screw out the temporary abutments, and we can handle this flow composite and reshape it and make it more smooth, more fine. And the final result, as you see, we have a customized healing abutment, one for the premolar and the second of the molar. So we get the same topography of the shape of the extracted teeth. And these two customized healing abutments will be left in the mouth for a time. Who will decide the needed time? It will be 1 week, 1 month, 2 months, 3 months. That depends on several factors. Depends your first implant system. Maybe you ask what is the best implant system. You can say very simply, the best implant system in the world is the one which make your work, your daily practice as simple as possible. The second factor, the lesions in the area. Is there lesions or not? We'll discuss this issue later with other slices. And the density of the bone and the insertion torque, of course, we'll discuss it later. In this case, as you know, this is bone density in the maxilla, not more than 500 Hounsfield. So it is D3 bone density with internal sinus lift and finished. So what have we done in this session? One session, we've got the extraction, the infection curative, internal sinus lift, inserting the implants, and finally we finished the customized healing abutments, and we send the data by email to the lab technician. After 6 weeks, 1 month and a half, the lab technician fabricate not two separated crowns. No, they are attached crowns. He built these crowns over like base abutments, and this is the final result. As you see, very nice osseointegration, 0 bone loss after 1 year, complete compatibility between the neck of the implant, so not the implant, the neck of the shoulder of the abutment and the crown itself. This is in the second session. No need for morbidity, no need for extra procedures, no need for more anesthesia for the patient. And the time of duration of this procedure was just about 20 minutes. So if we go to immediate implant placement, we have to ask ourselves a question. When it is possible to be immediate? When it is immediate? To be able to answer this question, we need, of course, to understand the main risk which we face in the immediate implant placement in the maxillary anterior region. If we want to understand the risk, we have to focus on the aesthetic outcomes, the final aesthetic outcomes. As you know, the main risk with immediate implant placement in the maxillary interior region for single tooth or single implant is the recession of the midfacial mucosa. This recession of the mucosa is a common problem. A lot of colleagues suffer from it, and we have bad feedback from our patient. Unfortunately, the science couldn't say its word till 10 years just before, to understand what is the criteria should be for these risk factors, which caused the soft tissue recession when we go with immediate implant restorations. So, the first issue should be focused on is the soft tissue. The issue is the soft tissue. The phenotype of the soft tissue is very important. And now it is completely demonstrated that thin phenotype can cause a great risk of soft tissue recession more greater than thick soft tissue phenotype. That doesn't mean that you can't get recession with thick phenotype gingiva, but the possibility in thin gingiva, thin phenotype is more greater. And even though in thick phenotype, maybe recession, there's ability to still happen. If the implant insertion was in malposition, in bad position, bad angulation, or if there is adhesions of the facial bone plate. So the chances of happening soft tissue recession is greater with thin soft tissue than with thick ones. So the case selection criteria for immediate implants, we try to look for cases that have a thicker soft tissue phenotype to minimize that risk. So the object of this slide, always think about thicker gingiva phenotype. If it is more thicker, you will be more happy. Under the soft tissue, you have to go to the bone, hard tissue. We have to look at the bone. Now, look to the bone phenotype. We know that if the select cases with a thin facial bone phenotype and compare it with a thick facial phenotype, we'll discover that the vertical resorption or the coronal apical resorption can be up to three times greater in those thin bone types than in the thicker bone phenotypes. So we have to measure what is the thickness of the labial bone. Unfortunately, when the facial bone resorb or collapse, at the same time, the soft tissue will lose its support and in turn can result in soft tissue recession. And the question now, what is the cutoff between a thin or thick? Nowadays, most people will accept that 1 millimeter or more of thickness, that means we are dealing with thick phenotype bone. And anything less than 1 millimeter as being as a thin phenotype. Another issue we have to put in mind, in most cases, we face thin facial bone phenotype in the maxillary anterior region. That means a predominant thin phenotype is always, in most cases, we will suffer from thin phenotype. So what that means immediate implant placement in the anterior maxilla may not be applicable in the majority of cases. Why? Because the bone phenotype tends to be relatively thin. So thin soft tissue with thin bone tissue, we are going to many problems. If we look to this slide, to this image, we face two problems. The wall, which should be cover the implant, is not exist. It's completely absorbed, and there is a total damage of the buccal wall of the facial bone, or we have intact bone phenotype. So what are we going to deal with, intact facial bone phenotype or damaged facial bone phenotype? So the other aspect relating to the facial bone wall of the socket is its condition. Its condition. Is the bone intact or has been damaged? Many reasons can cause this damage, maybe fenestration, hence, or other. So, if we inserted an implant with a damaged labial bone, if you do what you do of grafting, of GBR procedures, there is a much greater chance of recession of the soft tissue within just the first year of the implant insertion, and the problems will be more bigger. So take care the thickness of the facial wall, take care, is it damaged or it is not damaged, it is intact with the implant. So the inclusion criteria that we should be put in mind, that select cases that have an intact facial bone rather than cases which have damage to the facial bone. So facial damaged bone is not recommended at all for immediate insertion of the bone, of the implant. If we abstract the slices before, we have to look for thick tissue phenotype for the soft tissue, and for the hard tissue, you should deal with thick facial bone. We can notice that on the CBCT slices over the root, and this labial bone has fenestrations or dehiscence, or is it completely damaged, or it is intact facial bone. So the case selection criteria are pretty straightforward, and if we adopt these inclusion criteria that we have been recommended to use to us, this recommendation, we get it by the institute, the International Institute of ITI in Switzerland. So we are going to position our implants in a high degree of certainty, successful to catch successful outcomes. So we need thick tissue phenotype as much as possible and intact facial bone plate. What is preferable for extraction? Go with flapless method, or go for classic flap and elevate flap. It's preferable to go with flapless extraction and immediate placement. And that's, of course, need more concentration from the surgeon himself, especially when he deals with freehand surgery, or go to surgical guide solutions to control the 3D dimensional drilling protocols. So flapless extraction is better, but we have to control completely the dimensions, the buccal lingual, mesial distal, and the depth for further minimize the trauma to the facial bone. So when you don't elevate a flap, the trauma to the facial bone is very low, and you can avoid more bone resorption. So the recommendation here to avoid raising a flap if you can control 3D implant drilling and 3D implant insertion. What happened when we insert our implant at the same session of extraction? We have to keep in mind that should be the shoulder placement should be 0.5 millimeter to 1 millimeter apical to the facial bone, and keep a gap between the neck of the implant and the facial bone at least 2 millimeter. This gap, 2 millimeter gaps between the implant shoulder and the facial bone wall, for this reason that the graft, when you put a graft in this, and it should be allograft, when you insert the particles of the graft in this region, it becomes later a new facial bone wall, and it should be, and it needs an enough thickness to regenerate. So less than 1 millimeter, you can catch regeneration. You need a thick enough so that your provisional matrix can form all the clot followed by a new bone forming. But if the gap is too small, then there is a lesser chance for regenerating a bone wall that's which going to be thick enough to be available long term. If we are looking for long-term longevity, we have to keep 2 millimeters. What that means, we have to go to the standard of more bone, less titanium. Unfortunately, some colleagues, they prefer to insert wide diameter implants. That's not good at all. No need at all for wide diameter implants. So the first priority is for the bone. The first priority is not for the implant. The first priority is for the bone, especially we are talking about the interior region of the maxillary. We don't need at all 4 millimeter implants or more. We need maybe not more than 3.5, 3.3 is completely enough, and also 3 millimeter is enough. So the standard here, keep 2 millimeters gap as minimum for your graft. And the shoulder of the implant, please immerse it, put it down half to 1 millimeter apical to the facial bone in order to compensate for some vertical resorption of the facial bone. We know some little bit of vertical resorption will happen, so we have to compensate this loss of vertical resorption. So we have to place the implant deep enough to compensate for some of that vertical resorption. And put in mind, of course, you have to locate the implant towards the palatal aspect to maintain that 2 millimeters. Okay, to gain these golden 2 millimeters of bone, you have towards your drills, your implant, to be in a palatal aspect, in a palatal position, so that the biomaterial that we use for our bone substitute has ability to regenerate and form a new facial bone wall, which ultimately support the soft tissue. If we go back to the soft tissue, soft tissue is the issue. We have another aspect to the soft tissue. The soft tissue themselves can be collapsed once the tooth is extracted. Why? Because the tooth, of course, is no longer. So with immediate implants, a variety of techniques have been described to try and support the soft tissue, to stop the soft tissue, and to keep soft tissue support. We'll talk about two techniques. One is most popular and more common is the connective tissue graft. In these two images, in here in our slides, we can see that connective tissue, it should be, of course, harvested from the palate, and this is a weakness point. Maybe the patient will be not satisfied to catch another surgical procedure, and we insert this connective tissue into the buccal or the facial defect, and then a piece of connective tissue is used. That will be very effective. It is a very effective way, but of course, as we have a second surgical site in the palate, and that will cause, of course, little bit of uncomfortable for the patient. The other technique, we can support our soft tissue by the provisionals, with the provisional crowns. But here we have a standard. If you are going to use professional crown connected to the immediate implant placement, you should reach to 25 to 40 centimeters Newton. And I prefer 40 Newton centimeter. And the more accurate, you have to use ICQ machine from any company, maybe from a GQ, Dentist, or Hostel, or Penguin. These are respected trademarks, you can use it, but you have to reach to more than 70 value, ICQ value, and you have to protect the occlusion of these provisional restorations during the function, during eating, during chewing. So patients who have deep bites or patient never obey your instructions, maybe we can't add provisionals for them. We mentioned that if we are going to immediate placement in the anterior region, it is preferable to go with flapless technique, but sometimes it is necessary to open a flap. If you are attempting to insert an implant in the area and you have some difficulties in extractions, if you have surgery machine, it is very nice surgery to extract the tooth, to extract the root without in a flapless technique. But in some cases, you have to elevate a flap to get more better access to the root, or maybe you need flap elevating for grafting to repair the minor defects. In this case, we focus on minor defects, not wide defects. Okay, repeat, minor defects only. In this case, we have to insert the implant and submerged, to be submerged, and not immediately loaded, of course, because we want to maximize the regenerative potential of the implant and not sorry. We have to maximize the regenerative possibility potentially for the implant and not to interfere with the regeneration, not cause damage to the regeneration and not damage the osseointegration, especially in the critical coronal region of the implant shoulder. So, in some cases, we are going to go with immediate implant placement, but without loading. We go to conventional loading. If we need grafting, if we need maybe resorbable collagen membrane and closed sutures, maybe that's unable to load immediately for such cases. So it is essentially like an early implant placement, but done with an immediate approach. And then subsequently, we go to uncovering procedure and the restorative procedures. You can get very good outcomes, aesthetics, and functional outcomes as well. We can call this as immediate placement, but with conventional loading protocol. We are talking about immediate implant placement, but the opposite question, when not to immediate implant placement. This is the opposite question. We were talking about immediate implant insertion, placement, and now we are talking about when not to immediate placement. We have three categories: the infection and the damaged facial bone and thin phenotype. If there's an infection in the area of the tooth that you are going to extract, if somebody said if there is fistula, it is okay, you can get it, because the fistula will drainage all the ceramic solutions in the area. That's not true. Why? No fistula without facial bone damage. No fistula without facial bone damaged. If we go to the damaged facial bone, the whole implant insertion torque will be decreased. You will not reach to enough insertion torques. And if the facial labial bone damaged, what you do? Bone grafting. GBR, titanium mesh, you will not catch any perfect aesthetic outcomes after 1 year. The third one is the thin phenotype. The thin phenotype. As we mentioned before, the thin phenotype has a greater possibility for mid-facial recession with thin phenotype. If we go now to early implant placement, just to remember, early implant placement, that means after extraction, the tooth will leave the socket to survive, to resolve, to get complete healing after 8 weeks, about 2 months, or maybe extend this period to more than 2 months to give the bone opportunity to heal, but not complete healing. It will be a partial healing. So one of the reasons why you may delay the implant placement at the time of extraction if there is, as we mentioned before, an infection. So you want that infection to resolve and to re-heal and completely healing. If we ask ourselves how many times we have taken out a tooth, extract a tooth, and get back after 6 weeks or 8 weeks later to give the opportunity for the soft tissue to heal, and we discover that there's still something going on and hasn't quite completely healed. So sometimes we can't clear completely the infection site, even with deep curettage, just by taking out the tooth and curettage. The early implant placement, early implant protocol, we can approach to absolutely control if the infection has resolved, and we can have many clinical signs which give us a final decision about the health and healing of these soft tissues. So the infection in the soft tissue can delay the immediate insertion of the implant. So in the case of infection, we choose an early implant placement protocol to allow resolve and resolution to finish the inflammation completely. Another gain, when we leave 8 weeks after extraction, that in many cases the soft tissue phenotype at the labial plate is so thin, but when you leave it, you'll discover, as you see at the right image, the thin phenotype becomes more thick, and this is very positive point for us. We need it. So when we leave the soft tissue to heal for a period of 6 to 8 or maybe 10 weeks, we'll find a spontaneous thickening of the soft tissue, and that's approved by CBCT papers. Many papers, academic papers, researchers approved this point, that the thickening of the soft tissue, will enhance tissue stability around the implant and lead more aesthetic results for the long term. Why we go early? In many cases, maybe the facial bone collapsed. As we mentioned before, the dominant pattern of the facial bone is thin. It is not thick. So it is better to leave it to heal partially. There is a strange phenomenon called the flattening of the ridge. Flattening of the ridge. The reason of flattening the ridge is that the initial resorption of the buccal bone. But the facial resorption may lead to the flattening of the ridge, which will give us space to reconstruct the original contour. As in many cases, the facial bone after extraction, of course, it is concave. So it is impossible to graft any material onto the facial aspect. But in early implant placement approach protocol, we can do that so easily, and we don't worry about the facial bone. Okay, so don't worry about the facial bone. Let it give him the opportunity to resorb, and we will replace it with biomaterial later. So when we give the bone the opportunity for 8 weeks or 10 weeks, it will be more flattened. And if you go for GPR or contour augmentation, it will be more possible. And you can, at the same time of implant insertion, add the healing abutment and add the biomaterials, not to the neck of the implant level only. No, go more to the healing abutment itself. Maybe it will be 3 to 4 millimeter over the neck of the implant. Of course, we'll not gain here more 4 millimeter of bone, but this allograft, this substitute will encourage the nice healing of the soft tissue itself and increase its thickness. So your graft will support the soft tissue and it will be more thicker. But of course, before adding the allograft, it is better, as described by Danny Boozer in 2008, add bone chips, autogenous bone chips, locally harvested, and use it to graft and to cover the part of the implant surface itself. Then after that, you can add your allograft. When we go with early implant placement, we are going to more controlled over cam, more controlled aesthetic over cam, out cam. So when we delay the placement, it's sometimes indicated in the anterior maxillary region where you have extended apical defects that you cannot guarantee the reasonable primary stability. If there is a big, as you notice here, if there is a big lesion, extended lesion, maybe if you curate the lesion and get out the tooth, insert the implant, you will not reach to a nice torque insertion. You have to reach to nice torque insertion to guarantee the primary stability. So delaying 8 weeks or 10 weeks will give you more opportunity to have additional time to heal. But when you wait for 8 weeks or 10 weeks, put in mind that may be cause extended external resorption, which may make it impossible to place an implant. So cases like this may end with having complex GBR procedures. So if you have a wide lesion, extended lesion, it is unwise at all to insert the implant at the same extraction socket time. You have to wait for 8 weeks or 10 weeks, but put in mind, maybe you lose more of bone and maybe you are unable at all, even after 10 weeks or 8 weeks, to insert an implant, and you have to re-establish the whole position from zero by complicated solution from GBR. At the end, early implant placement, we have always to think about what we have: thin, soft tissue phenotype, or thick. Thick is better. Do we have thin facial bone phenotype or thick? Thick is better. We have damaged facial bone or intact facial bone. We prefer, of course, intact damaged bone. Don't forget at all that the dominant shape of the facial bone is thin. So, as a final abstract, early implant placement in the anterior region should be a default procedure, not an option. We have to deal with it as a default option. So extract and wait for 8 to 10 weeks, and you'll get the best aesthetic results. Thank you for joining our webinar. Thank you for listening. And if there's any questions, I'm waiting and listening. Good evening. Thanks, doctor, for valuable information. My question is, in cases with a slight infection or mild inflammation after extraction, then slight infection or mild inflammation after extraction, do you still consider immediate replacement a safe option, or would you rather delay? Okay. We have many criteria to answer this question. It is a very nice question. First of all, during the reading the CBCT slices, the cross-sectional of CBCT, look to this infection, mild inflammation or infection. Has a direct borders? Its borders are clear, or it is extended during the sponge bone. If the borders of the lesion are clear, it is clear, you can go with extraction and curate the area to hair, bone, let's say bone crush. So it is okay. This is first of all. If it is not clear, I don't advise anybody to insert the implant at this time. So another issue, if there is a fistula, some people encourage, some people not. Actually, I don't encourage to bend on fistula to drain all the edema solutions, and I hope to leave the spontaneous healing. So go after 8 weeks or 10 weeks without any problems, and you get a semi-completely healing of the bone of the lesion. Thank you again. Is there any questions here? Of course, there are many factors, depends the immediate implant placement and protocols for healing, the implant system itself, and the density of the bone, and the occlusion habits of the patient. Maybe after 1 month, there will be another webinar. We'll discuss these other points. See you برعاية الله وعليكم السلام ورحمة الله وبركاته.